Welcome to yet another training module for NICU nurses. Today we will discuss a little bit on sugar monitoring in newborns. What is the definition of hypoglycemia in a newborn? Now, we have a consensus definition on the operational threshold, that is any blood glucose level less than 40 milligram per deciliter is considered hypoglycemia in a newborn. Now, whom should we screen for hypoglycemia? Do we screen all babies for hypoglycemia? No. We have some babies who are at risk for developing hypoglycemia. So these are the babies we screen. They are the low birth weight babies, especially those less than 2 kilos, then preterms, SGA and IUGR babies, infant of diabetic mother, large for gestational age babies, sick newborns, and babies with RH devices. What are the symptoms of hypoglycemia? It is important to note that hypoglycemia need not always be symptomatic. They can be asymptomatic, and this is why it is important to screen those high-risk babies for hypoglycemia. And symptoms in hypoglycemia can be non-specific, like just jitteriness or lethargy, poor feeding, sweating. It can be as severe as seizures. Now, when do we screen these babies for hypoglycemia? We have a schedule. So the at-risk babies should be screened at 2 hours of birth, 6 hours of birth, 12, 24, 48, and 72 hours of birth. Whereas sick babies, we don't stick to that schedule, but we individualize and check blood sugar according to the need. Now, it is extremely important that whenever we check sugar, it should be just before feeds. Now, how to screen for hypoglycemia? Though the gold standard is a lab diagnosis, it is not always feasible. So we check with a blood glucometer. Now, though we can use a glucometer, it is important that we recheck or counter check the hypoglycemia by sending a venous sample to the lab. However, it is important that we don't actually wait for the lab result to start treatment. Where to prick? It is important that we prick only in the areas shown here, the marked area shown here. We don't prick in the area of the calcaneal cartilage. Initial treatment of hypoglycemia, uh, it is important to categorize the newborns as symptomatic and asymptomatic. If baby is symptomatic, including seizures, we give an initial bolus of 2 ml per kg of 10% dextrose, that is followed by a glucose infusion rate of 6 milligram per kilogram per minute. However, if baby is asymptomatic, if the blood sugar is between 20 and 40, we give a trial of oral feeds and then repeat sugar after 1 hour. However, if sugar is too low, that is less than 20, then we don't give a trial of oral, we straight away start IV. However, here we don't give a bolus, we start straight away with infusion, because bolus IV has the risk of the baby developing rebound hypoglycemia. Then we monitor sugar hourly till the baby becomes euglycemic. After that, we check it 4 to 6 hourly. Now, the take home important messages are: it is important that we understand that hypoglycemia can permanently damage the brain. So, we have to follow this mentioned protocol. And a baby developing hypoglycemia or seizure due to our negligence is unpardonable. Thank you so much.